So welcome. We're beginning to get our participants. I can see the sort of numbers rolling at the bottom of the screen. So as we're waiting for everyone to sign on, I just want to welcome everyone to this webinar on primary care and the COVID-19 response with Farzad Mostashari and David Chokshi. We're gonna let all of you people sign in. While we're waiting for everyone to do so, just to let everybody know, we will in fact be recording this and posting it on the PCDC website, which is pcdc.org. So we will welcome you to take a look at that afterwards and to share that around. Also want to mention that we have, this is the first in a series of webinars. Please use the hashtag on Twitter, COVID-19RRR. What that means is relief, response, and resiliency. And we believe that those are some of the key things that we need to be focusing on in this moment as we are responding not only to the COVID pandemic, but to the needs of our communities for much greater access to and high quality primary care. So we'll get started in just a minute as we see that a lot of folks are still signing on. Just to let you know, there will be questions. You can use questions, the question and answer function at the bottom. If you want to ask a question, we'll get to them as best we can. And we will be recording, as I mentioned, and allowing for conversation. But want to welcome everyone to this webinar. Let's move to the next slide, just so that we can share that this is the first in a series of webinars that we'll be holding on relief, response, and resiliency for primary care in the COVID-19 pandemic. So today we're talking about what we need today to strengthen primary care in terms of the COVID-19 relief and response. On May 21st, we'll be talking about the new normal, how primary care can reopen and reboot. And Thursday, May 28th, we'll be talking about what should the new normal look like? What should we hope for in a revitalized, reimagined primary care system that will be able to participate not only in thinking about epidemics, pandemics, but also really the fundamentals of primary care. So we're looking forward to all of you joining us for that. So I think we'll move on to the next slide. As I mentioned, the Primary Care Development Corporation is a national not-for-profit. We're a community development financial institution. And our mission is to ensure primary care access and quality, particularly in low-income, disinvested communities, many of them communities of color and rural communities. And we do that through providing strategic community investment, technical advisory services, and advocacy with the end goal of achieving health equity. And we know all of you out there share those goals as well. So if we can get the next slide, I want to introduce our two speakers today. So first we have Dave Chokshi, who is, as you can see, the Chief Population Health Officer and Vice President at New York City Health and Hospitals. He's also the CEO of Health and Hospitals Accountable Care Organization and a clinical associate professor at NYU School of Medicine and a practicing primary care physician. I also want to note that he's a very important member of the PCDC Board of Directors as well. And Farzad Mostashari, who many of you will know, is the CEO and co-founder of Aledade, which operates ACOs, Accountable Care Organizations, across 25 states with 300 practices serving more than 650,000 patients. He's the former National Coordinator for Health IT at the U.S. Department of Health and Human Services. Before that, he was at the New York City Department of Health and Mental Hygiene, where he founded the Primary Care Information Project and led the CDC-funded Center of Excellence in Public Health Informatics. And I want to thank both of you for joining us today.
And Louise, you didn't mention that it was where I had one of the best bosses I ever had.
Well, that's true. And who was that, Farzad?
That was Louise Cohen. I don't know if you know her.
You know, I think both of you are great colleagues and people I really look to for strategic advice and thought. So as we thought about who should be talking about primary care today, I thought of the two of you. So let me just kick this off immediately. So interesting, Axios had a headline this week that said, coronavirus is obliterating outpatient care. Is this your experience? What are you seeing in New York City and Farzad around the country? How has primary care been affected in the last 10 weeks? What's been going well? What's been going badly? Farzad, let me ask you to start.
Sure. So we're now in 29 states, Louise, 550 practices, almost 1 million patients under risk contracts. And these 550 practices range the gamut from solo practitioners, primary care practitioners, to larger primary care practices, multi-specialty clinics, and then a lot of FQHCs, rural health clinics as well. So really the entire gamut of primary care. And what I can tell you is that it is bad out there. And just to put it, and I think your audience knows this, one of the first things that we realized was going to happen was that visit volumes were going to crater because our practices were telling their patients to stay home and stay safe. So to protect their patients, they were the only way that under the fee-for-service face-to-face visit driven system, that was the only way they were getting paid for their operating budgets. The other concerns was the supply chain was broken. So they couldn't get access to PPE. If you think hospitals have a hard time getting masks, just try being a 2-doc practice in rural Arkansas and trying to call your usual supplier and try to get masks for that. The third issue was we started getting very early on practices who were exposed and had to go, where healthcare workers had to go into quarantine. We've had several physicians hospitalized. One is intubated right now. And they're still showing up to work. And their practice partners coming to work again, seeing patients who need their help. And they're going broke while they're doing it. And they're having to lay people off while they're in the midst of this, of worrying about everything else going on with the pandemic. They're also terrified of whether they're going to be able to keep paying the bills, which is just an absurdity that's the situation we've put folks in. So visit volumes are down. Our practices are the best case because they've embraced value-based care. They have alternative sources of revenue on shared savings contracts, and they're part of us. They're part of a larger network we're helping them get, and I can talk more about helping them get on televisits, understand the regulations apply for all the financial stuff, get PPE and all that. And visits are down 40, 50, 60% in some cases.
Great, Dave. Why don't you tell us what you're seeing in, New York City, the epicenter, Bellevue Hospital, where you are, the epicenter of the epicenter.
Sure. Let me just check. Are you able to hear me all right, Louise?
Yes.
Great. And I really want to thank you and PCDC for sparking this really important series of conversations. Yes, I'll offer the lens from New York City, which, for so many of us who have been working on COVID-19 response here, it's been the most intense and harrowing few weeks of our lives for the reasons that Farzad, has pointed out. But I think that, amidst all of the focus of the direct effects of the virus on people, on patients and families, what is happening to our primary care system, really, in concert, is unfortunately not sort of rising to the level of prominence that we need. It's a little bit like, as a doctor, it's hard for me not to think in clinical analogies, but it's a little bit like what we see with the virus itself. You have the direct effects of infection, and then you have this immune response that follows close after that is almost as catastrophic itself. And that's a little bit of what's happening with the rest of our healthcare system outside of hospitals, I think. So I agree with Farzad. I don't think it's hyperbole to say, as that Axios headline did, that the coronavirus is obliterating outpatient care. In New York City, so much of what has happened in the ambulatory sector has been part of the response to making sure that the patients who were the sickest got the care that they needed in hospitals. So I'm so proud of my colleagues at Bellevue and elsewhere who rose to the challenge. People who had not practiced inpatient medicine in decades, taking care of people on the wards. My favorite story is that there was a group of outpatient child psychiatrists who sent a note to the director of the medical ICU and said, look, we're going to need a lot of supervision, but we're ready to do whatever, minutia you need us to do if we can pitch in and help. But at the same time, I think about it sort of in denominators, which I know both of you will appreciate. There are thousands of patients with COVID-19, but just in our system alone, there are over 1 million patients who don't have COVID-19 who also have pressing healthcare needs. And so I worry about that broader denominator of millions. I'll wrap up this opening part just by saying that even as all of us are wearing masks, going about our daily lives in this new normal, it feels like what's happening is, as a result of COVID, is an unmasking of so many different phenomena. Just as there's, systematic underinvestment in public health that is being unmasked with respect to its consequences, it's a systematic underinvestment in primary care that is similarly, showing really dramatic adverse effects. The other unmasking, Farzad touched upon really nicely, sort of the tyranny of the in-person visit and having, so much tied to the churn of whether or not, there are specific visits rather than delivering care in other modes. And a lot of the unmasking has to do with the limitations of fee-for-service medicine, which I know we'll get into.
Yeah, so let's sort of dive into some of the details of it. So telehealth, Farzad, you and Aledade jumped right into telehealth. You helped all your providers kind of get up and running, and telehealth can be part of the solution in this moment, but is it the whole solution? What's working, what's not working around telehealth?
Yeah, we realized very early on, this is where having a background in medical epidemiology, I didn't suspect was going to come in handy. But we recognized that this was going to happen, and we did a full-on procurement in 6 days. That's the other thing that actually the one positive I think that we can take away from this experience has been that we realized that all the things that we used to believe that things can't change, it's going to take years to do X and months to do Y. It turned out that's not true. That we actually can do things in a matter of hours or days in our healthcare system, even on the payment side and regulatory side, as has been shown. But we did a full-on procurement for a telehealth solution, 17 vendors in 6 days, and made it, contracted for, donated to our practices. Now for the first 5 months, it's going to be, they don't have to pay for it, just so they can get over the hump on it. And we stood up 150 practices over a weekend so that they could start seeing patients on Monday without exposing the patients, exposing themselves, and without letting the untreated chronic diseases continue. So we went from 100 televisits in our cohort to 10,000 televisits in 2 weeks, 100 to 10,000. We're now over 20,000. I think 40% of all visits now the volume is down, so it's 40% of a lower base, are through telehealth. And it doesn't matter whether it's a standalone solution or whether it's something that was integrated into electronic health records. It's about 40% across both of those. What are some of the pluses? I think in some cases, it's like there was a lot of fear around it, and it's proven unfounded. Even 95-year-olds can do telehealth, and even rural practices and small practices with old technology can do telehealth. I think providers realized that there were some cases where there was an advantage. Doing transitional care management, one of the big challenges was always after the patient got discharged from the hospital, getting them back into the office when they're post-hospitalization. turns out it's a lot easier to do that. And you also gain valuable insights about the home environment with a televisit. So there's some positives there. But as one of our docs said, like, he had a guy come in with a fish hook in his finger. Right? Like, you want him to go to the emergency room at a time like this, right? Or do you need to have a place where people can go? So there are limits, obviously, to telehealth. My hope is that this will be, and my hope and my belief is that this will have been a fundamental acceleration of telehealth becoming a core part of how primary care is delivered.
Yeah, Dave, any thoughts for you on telehealth, telemedicine, its role and its limitations?
Yeah, I do think that it's going to be a quantum leap for telehealth, and so many of the things that have changed in the last few months will persist, and I do think that's one of the silver linings of what's happening with COVID more broadly. Just as Farzad is seeing, with his practices in our system, we went from about 500 televisits in the month of February to 50,000 in the month of March. So just a tremendous uptick in a short period of time, and really, people embracing it on both sides. Clinicians who perhaps weren't as comfortable with the technology or the workflow, embracing it, as well as patients, seeing some of the advantages, particularly for the patients that we serve, who tend to be low income, poor and working class New Yorkers, realizing that it's a way not just to maintain social distancing right now, but also it gives them back some of their most valuable commodity, which is time, with respect to the time required to commute, to and from one of our clinics or hospitals. I'll just offer a little bit of a clinical perspective as well. I did a session this morning here at Bellevue, which was all telehealth, and there is a lot of good that we can do. For me, because I've been taking care of my panel of patients for several years now, there's been so much that we can offer with respect to reassurance in a time of great anxiety. And, it helped. This is the bread and butter of primary care, the relationships and the continuity that people really appreciate about primary care are particularly salient at a time where there is so much uncertainty and anxiety. I worry a little bit about how that will look going forward. It's easy for me to deliver care with patients with whom I've already developed a relationship, but it's much harder, in a new patient visit to have the same rapport that one is able to get by laying a hand on someone's shoulder, when they're relaying something very difficult or worrisome. And there are other challenges to telehealth itself, and Farzad alluded to some of these. Some that I've experienced is it's a little bit more difficult to pipe in interpretation services with the video visit, for example. So we're doing it sort of in an old-fashioned way. We use a video channel and then an audio channel, to be able to use our interpretation services that we have. We're also working out some of the kinks in our workflows. We started our move to video visits by calling up patients to essentially prime them for the video visit, and we found that turned into a telephone visit. They wanted to talk about clinical issues as part of that as well. And then the final thing that I'll say is that again, there are some pros here. I've had many more conversations with family members, with people just passing the phone around, again, because people are worried about specific things, and everyone is within the same home environment. And you get some of the same benefits that you do from an actual home visit. It's just a more natural place to talk about cooking and grocery shopping and exercising at home. when the patient is already there. So so I hope that some of those things we'll be able to preserve even as we address the challenges.
Yeah, I think telehealth is one of those things where when it works great, and when it's not quite right, it doesn't work. One psychiatrist I know described it as trying to do therapy through a keyhole. It's like you're only seeing a certain amount of things. On the other hand, some of the literature shows that people feel freer saying things over a video and a telephone, where we share so much on social media, that it's kind of an interesting, give and take on what it works and how what it works for and how it works. So, but I do want to jump into this issue of deferred care. I'm sorry, Farzad.
Louise, I just wanted to jump in. I thought Dave had a really interesting and important point for people to realize as they're embracing telehealth around workflows and around efficiency. This is, some of what the value that I think people come to PCDC for is around the finances of healthcare. And, you would never start a practice and assume that you figured out how to do the most efficient patient, rooming workflows on day one. And, one of our providers said, oh, but I'm less efficient on telemedicine than when I can go bang, 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 room, and like everything works like when it works in in-person visits, like it's a smoothly oiled machine, and you got people roomed and they're being interviewed, and the nurse does this and the care, coordinator does that. And and that's what we're working on now with our practices, is actually, now that you have the raw tool, now is the time to actually focus on efficiency and workflows and who does what and how do you address those issues so that you can actually get productivity. Theoretically, you should be able to get it higher than you had before when people had to physically move around.
Yeah, I think those are real challenges, trying to figure this out, and how you engage other staff in a phone conversation, and how you pass off between a medical assistant and a nurse and a provider. But let's talk about deferred care. I mean, Dave, you've called deferred care a second pandemic, and I want to know what you're worried about and how we can address it.
Thanks, Louise. Well, this is another area where I think we really shouldn't mince words. There will be lives lost as a result of care that is being deferred right now. Yes, people have called it the second pandemic or a shadow pandemic. It's composed of a few different phenomena. So let's, try to break some of them down. And we actually have data on many of these things emerging at the national level. Childhood immunizations are down significantly. There was a CDC morbidity and mortality weekly report, that charted this very steep drop, that was correlated with declines related to COVID. There's data indicating that there's an almost 90% drop for certain cancer screenings: cervical cancer, colon cancer, breast cancer, and then there are mental health consequences as well. Related to both the additional stress and trauma that many people are experiencing, and constraints with respect to access. So I hope that there will be a snapping back of sorts. All of this that is being deferred will work through a backlog, as we start to bring things back online. But I really worry about people who, will forego care as a result of the challenges that we'll continue to have with respect to access. And again, I have to just share a little bit of the, my own experience taking care of patients, in that a lot of those numbers, and even though we should really focus on mortality as the worst, outcome to track with respect to illness deferred, there's also just a lot of suffering that has to do with quality of life. I had a patient who had a kidney stone, which is one of the most excruciating, types of pain that one can ever experience, and was really struggling with whether or not they should go to the emergency room, to get some IV pain medication, which is what would have normally happened. and they ended up suffering with that kidney stone at home because they were afraid of the risks related to COVID. So, so I think all of these things, and particularly, the chronic illness care, which is directly related to outcomes with COVID-19, are things that we're going to have to pay closer attention to.
Dave, if I can ask you, in New York City context, some former colleagues in the health department published a report where they found a large number of other deaths, many of them cardiac origin, many of them at home. Do you have any clinical intuition as to what portion of those may have been the direct effects of the viral infections affecting arrhythmias and cardiac direct effects of the virus versus untreated conditions?
Yeah, it's very hard to know, until we get some more evidence that emerges. There was that report, I think you're referring to another one that was published in the MMWR from our colleagues at the City Department of Health. And, at least the preliminary data indicates that at least 20% of the so-called excess deaths over the last few months cannot be directly attributed to COVID-19. And so we'll see, where that proportion settles out. But I think almost certainly it's going to be a significant number of people who didn't seek care, related to fear and just related to this new world that we're in.
Farzad, I wonder how much of the fear of actually going to a primary care provider's office is so acute in New York City, I think, because of the numbers. But tell us about what you're seeing around the rest of the country: diabetes, hypertension, CVD. What are the primary care folks seeing out there in terms of that kind of deferred care?
Absolutely. It's not just New York City. It's even parts of the country where the virus has had not that much community circulation yet. People are afraid, and they are absolutely deferring much needed chronic care. One of the things that we're creating a program around now is getting data from SureScripts when a prescription is not filled. There's tons of, and I'll tell you, we're getting lots of alerts of people who are not filling their blood pressure medications. They're afraid to go to the pharmacy. They're not getting their blood pressure medication filled, their diabetes medication, their statins. So, we're having to put in programs for 90-day mail order to identify those folks. There's a ton of fear about going into the office, and in some cases it's warranted. In other cases, the damage from that is going to be greater than the risk they would have faced.
And if I can just add, Louise, a little bit here, at the risk of stating the obvious, I think, some of the trends that we've talked about already are connected in the sense that we have all of this foregone care that we've acknowledged, is very worrisome. But at the same time, we have capacity, on the primary care side. We have excellent clinicians and care teams who are not as busy as they were in January or December. And so, I think, just to name, part of our challenge is to solve that mismatch between demand and supply, and it's going to take policy and money to do that.
They're laying people off. I mean, this is insane. It's insane. When you look at the March employment numbers, after the hospitality industry, the sector that lost the most jobs in America was ambulatory healthcare. And our, the whole premise behind what we're doing with value-based care is more primary care means fewer bad things happening to people, right? It's as simple as that. And all we do is we get more informed, more engaged, more accessible primary care, and that creates savings. Now reverse that. What happens if instead of increasing primary care, we're decreasing primary care? It is absolutely a seesaw, and we are going to pay for it. And 3 months from now, people are going to be looking at this devastated landscape where those practices are out of business and they're no longer there. And they're going to be saying, you know, the CDC guidance says, if you have this symptom, call your doctor. And they're going to call and no one's going to pick up on the other end of the line. And we're going to be saying 3 months from now, we're going to be saying, why didn't we do something about this 3 months ago? Why did we put $175 billion? Let's add another $100 billion for provider relief and dedicate none of it, not a dollar of it, dedicated to primary care.
You know, amidst the, I mean, I agree, and I think that's it's, you know, well stated and cogent, and you know, I think we all need to feel that same sense of urgency to offer, you know, at least a little bit of a way forward. And I know, you know, Farzad and Aledade have led on this as well. I think part of the way to start connecting the dots is to make it clear how uncontrolled chronic disease is tied to worse outcomes in COVID-19, and to do the things which I agree are easier to do in a value-based care environment, to reach out to patients who are most at risk. You know, a lot of what is the bread and butter of what, you know, I would consider population health in the first place. You wrap your arms around the denominator of, you know, patients who are attributed to you, to whom you are accountable. You figure out who is at greatest risk, and you try to match up services to that group. And I think we have to sort of evolve and be more sophisticated about what we consider as risk in this context, but the principles are all the same. And I think it's a way that we both need to be very operational, but also, you know, start telling the story about how these are not, you know, one of the ways that calling it a second pandemic may not be helpful is that it makes it feel like it's separated when it's actually not. You know, these are all part of the same set of problems that we all have to work on.
Louise, can I jump in there again?
By all means.
Thank you. This is awesome. There was you know, CMS has done so much and so much good with the regulatory powers that they have. I really have to give them tons of kudos, but they absolutely messed up one decision, and they put out an interim final rule with comment, it was last week, things moving so quickly, where they basically said, you know, this ACO stuff, you know, if you're in an ACO, you keep doing what you're doing and we can extend your contract, but no new ACOs for 2021, because people should be able to focus on COVID. And it's just such a fundamental lack of understanding that ACO work is COVID work, right? We're an ACO company, and what am I doing? What are my people doing? We're helping get telehealth set up. We're getting PPE for practices. We bought 386,000 masks for our practices. We're sending 100,000 postcards to patients to tell them to stay home and stay healthy. We're working out the practice workflows. Why? Because, as Dave said, population health is, the whole concept is you're accountable for these people, and go keep them safe and do wellness at home and find out if someone went to the ER and call them, right? That is COVID work. And to say, oh, focus on COVID, you don't need to worry about ACO work, is such a fundamental lack of understanding that population health and value-based care is not something on the side. It's a fundamental change in perspective of making sure that everybody counts and we don't leave any vulnerable people behind.
So I think that you know, this issue of, like, this shows the stark relief of the fact that we don't do population health, you know, all that well throughout the country, notwithstanding, you know, Aledade's work or you know, anybody else's work, but sort of as a country, we're not, like, we haven't really figured out how to do this well. And I think we don't have prospective payments. You know, a lot of our value-based payment is tied so much to, you know, this program for this insurer and that program to that insurer. There isn't this concept of prospective payment. And you could imagine that if you really had prospective payments, primary care providers would not have to be laying off their staff, because they would have a steady, global prospective payment, they would know what they're getting for the people that they take care of, and with some amount of fee-for-service for new patients and for emergencies and all those things that really probably should be financed through fee-for-service. But there's, a lot of the basics of how we fundamentally finance our healthcare system, aside from the fact that primary care gets 5 to 7 cents on the healthcare dollar, which is in and of itself already a problem when you're really talking about all the things that we want to make sure that that people have access to. So I don't know, is it time to seriously talk about a global prospective payment system and move, just jump right to that and think about that as the answer for, or one of the major answers for primary care? Is that, and do you think that's politically feasible in this moment? Have we shown enough how much, or are we still going to have to get deeper into this hole before we can show that as the answer?
Yeah, I have a couple of thoughts, and I know Farzad does as well, since he's he's worked on these issues for many years. Yes, this feels like we know where we have to get to with respect to how to restructure payment to address these patient care and delivery issues that we've talked about. And I do think however you want to think about it, prospective payment, global payment, accountable care, that capitation, I think the argument for it is stronger and perhaps more self-evident, as a result of what's happening. I do hope that, there will be kind of a wave of evidence that emerges about how the Aledades and other ACOs and some of the other value-based care entities that exist were able to more nimbly shift into the new world that we found ourselves in many cases literally overnight. And I think that will be very important to sort of shore up the argument for the need to move to that payment. But I worry a little bit about the bridge, from here to there. And I don't want us to be, tone deaf at the same time to argue for that, medium-term policy while people are really suffering right now.
Thank you.
Both, are the clinicians on the ground, as well as the patients who are missing the care, that we've talked about. And so I think there have to be some more immediate steps that pave the way to build that future.
I couldn't agree more. I think there is opportunity, but right now they're drowning. You throw them a lifeline. You don't say, now let's teach you how to swim breaststroke. Like someone's drowning, right? Throw them a goddamn lifeline, right? And let's, like, if it's, $50 a month, sustainability fee or a access fee or a $200 one-time payment. There's been lots of proposals around from primary care groups and kind of policy folks around, let's do immediate relief for these practices so that specifically targeted at primary care. And I think one of the challenges, Louise, that we have to address is this feeling on the Hill or whatever, that, well, everyone's got their hand out. Oh, everyone's got their hand out. And oh, everyone's hurting. The restaurants are hurting, the dentists are hurting. And like, we gotta say, listen, this isn't about you saving primary care. This is about primary care saving you, right? Like you want to control this outbreak? You need primary care. Restaurants aren't going to help you control this outbreak. Primary care is what's going to help you control this outbreak and the sequelae of it. And we need to be paying special attention to primary care. And that simple message, Louise, has not gotten through. So we need relief. I do think that you can design these things where it bridges over. That monthly $50 monthly payment then turns into a $50 primary care cap fee with a total cost of care adjustment on the other end of it. The telemedicine payment parity, over time, you're like, well, are we going to continue that? There's a lot of fraud and overuse possibilities with this telehealth stuff, maybe only for people who are in total cost of care contracts. So I 100% agree with Dave that we lay the bridge and the pathway in the medium term to new payment policies, but right now we need a lifeline.
And I think, part of the bridge is very tangibly demonstrating, the value that primary care is providing. Again, there are countless examples of very motivated, mission-driven nurses, PCAs, doctors, all stepping up to what is needed right now, expanding our testing capacity, participating in contact tracing in collaboration with public health departments, doing, all of the things that we know we need for, for the larger COVID-19 response, but, sort of showing that it's brought, I'm sitting at Bellevue Hospital right now. So much is happening at hospitals. It's extremely important, but the healthcare system extends beyond hospitals, and particularly, like where we are in New York City, having survived, at least the initial surge, we have to make it more of a big tent approach with respect to what healthcare has to contribute. And I'll just give you one other very concrete example of this that is really in my mind over the last few days, which is antibody testing. There's so much uncertainty about antibody testing, as we know. They're tests of exposure rather than tests of immunity, at least thus far. I've had several conversations with my own patients about working through that uncertainty. And again, this is what primary care does best: navigate uncertainty through trusted relationships. And we're going to need much more of that to get through the next phases of the pandemic.
I think one thing that's really been startling to me is that this is a public health emergency, yes, but it's also a healthcare and primary care emergency. And I'm really concerned that someone who comes to a testing site is concerned about their symptoms. They test negative. Who's taking care of them? Who's managing their hypertension? I heard from one nurse who was at a testing site, 100% of the people who came in had elevated blood pressures. Who's following up with that? How are they getting taken care of? Who's managing that? And then if they're testing positive, but they don't yet need hospital level care, and hopefully we can avoid that, who's managing them? And to me, I guess the question is what is now and what should be the relationship between public health and primary care to manage through this COVID period, not only because it'll help us down the line with deferred care, but right now, today. Right now. And I think that is a very serious situation that is, I haven't seen very many examples around the country of where this is being thought of strategically. There's a plan, it's working all well together. Have either of you seen really good examples of that? And what do you think we should be doing to make that happen?
Scott Gottlieb, Mark McClellan, and I wrote a surveillance plan for National COVID Surveillance Plan as part of the Duke Margolis Center and AEI. And one of the things, not surprisingly, one of the things that was in there was around primary care needing to be on the front lines of this. But if you think about it, like, we're reopening under the assumption that we can do contact tracing to make up for some of the loosening of the physical isolation restrictions. And we have a modeling paper that just came out. The key sensitivity factor for contact tracing working is that you diagnose a significant portion of people who have it soon. You can't have 10 days between onset of symptoms and the reporting of that case. You do that, you're dead, because all of the people that person was going to infect, they've already infected. Not only that, all of their contacts have already infected all the people they're going to infect. So if you want to have an effective, and we're going to be pumping billions of dollars and hundreds of thousands of people at contact tracing, it's only going to work if you get early diagnosis. Where are you going to get early diagnosis? Is it going to be Walmart? No, it's not going to be. You're going to need to tap into every single site of care where people usually go for coughs and colds and flus and aches and difficulty in change in taste, right? You're going to need to arm those front line. When I say front line, like, I mean front line. Like, who's the first point of contact with someone who has the symptom on day one? It's going to be, go to your primary care doc And those primary care docs have to be prepared to do rapid testing, point of care, and reporting to public health. And then the second point you raised, and what we also gave recommendations for, is pay them. You want people to do more stuff? Pay them. Like, you want to get more, like one thing fee-for-service has proven is good at is increasing utilization. You want to get more specimen collection from primary care? Then don't pay them $8.24. Like, pay them for the cost of 4 changes of PPE for me and my staff, and to be able to disinfect that room, right? Pay for specimen collection, pay for testing, and pay for episodes of contact tracing. The example that Dave gave is perfect, right? You identify someone, you put them in a hotel, and you say, monitor your health for 14 days. Who's going to do that? What happens when they say, actually, I'm having maybe a little difficulty breathing? You want a clinical person on the phone there to be able to advise them. And we need to have payment that makes use of that capacity in primary care. It's not complicated, Louise. We just have to do it.
Yeah, I think there's a big disconnect, because a lot of those people in those hotels for 14 days are also going to have high blood pressure. They're going to be dealing with their diabetes. They're going to be, it's one thing a contact tracer might be able to help with, oh, here's where you go for, we'll make sure that you get food delivered to you and all those things. But I do think that the clinical voice, we need to use our clinical voices. And it's not only the people who work in hospitals who right now especially are focused on more acute care. We want to make sure that all those people don't need acute care in the future. So I also think though that people who test negative, people who might be the worried well, those are also folks who need a lot of follow-up. And the best place to do that is not an emergency room. The best place to do that is with primary care. And to your point, we have to pay folks to do that as well. So just to let you know, we have about 15 more minutes. I guess I want to ask 2 questions. And then we have some interesting questions from the audience here. One of them is, what do providers need to reopen safely and successfully? I was struck by one primary care provider who said to one of our staff, I'm worried because if someone with COVID comes in, I'm going to have to disinfect everyone. I don't have the PPE. But here's the thing. It seems to me now we're talking about universal precautions, right? You have to assume that everyone's coming in has COVID. But how are we going to get all these primary care providers open again? What do we need? We need payment. We need PPE. How are we going to get that? What else do we need?
Yeah, I mean, I like Paul Farmer has a framework for this, the 4 S's: staff, stuff, space, and systems. And so just going through, each of those briefly. I would start with stuff. We have to prioritize the safety of the workforce. That is the fundamental precondition for everything else. And so figuring out, the flows to ensure that there is adequate PPE and everything else that's needed to protect, both staff and patients is fundamental. So that's the stuff. For staff, it's striking the balance between, in a system like ours, we still have a lot of our outpatient staff who are shoring up our hospital care, and figuring out the right balance between some of the tents and the other spaces that we have set up for testing, and sort of the new normal for ambulatory care, which is almost certainly going to have to be a blend of starting slow with in-person and a lot of virtual care. So I think those are the major challenges around staff. And then briefly, I touched on space, but this will require, reconfiguring how we think about designing ambulatory practices, both, to have specific spaces that allow for the protection of staff, as well as, working out the kinks, as Farzad alluded to, to gain the same efficiency that was done over years in many ambulatory practices. And then finally, systems, a big part of it is virtual care. But another part is everything that allows us to take care of patients with respect to testing and contact tracing as well. So that's how we're starting to think of it.
I loved your 4 S's or Paul Farmer's 4 S's and your use of them here. I would add a 5th, which is surveillance. So we don't know, if you think about the country as a whole right now, there is nobody, nowhere to go. I have a dozen tabs open trying to figure out what's going on with case changes in case counts and testing rates, positivity rates, what's going on with death rates in Iowa, what's going on with the PNI, Sentinel ILI-net, what's going on, right? And we are all, the Facebook symptom survey I'm looking at daily now. Like, we're going nuts trying to do what is actually somebody's job, right? Whose job is it? It's the CDC's job. And they're not being allowed to do their job, which is to provide a nationwide, what was promised to the governors back in March, right? Which is, we'll give you county level, if we can, sense of what's happening with the outbreak in your communities. And we have gotten exactly zero of that, right? There is no dashboard that tells you who's red, who's green, who's yellow, so that people look. It's not, you have to do universal precautions, Louise is right. But when you're in a red area, you should be acting differently. You should be taking different levels of precautions. It's all about your pretest probability. And we're not, and like, my company is having to develop a surveillance system that green, yellow, reds, the zip codes for our practices. We should not have to be doing that. And like, it's nuts that we don't have that fifth S of surveillance available for practices.
Right. And as both of you have pointed out, then we need funding for all of those things. The best way to do it, there's a bridge, but there's also then a global prospective payment, and, whatever quality metrics and total cost of care you want to tie to at the back end makes some sense. But right now we actually just need that funding to flow, the PPE to flow, the funding to help people reconfigure their physical plant, whether it's putting up plexiglass or whether it's thinking about negative pressure rooms, and so forth. So let me just go to one question that I thought was really useful from from our audience, and thank you for putting that in, which is, are you all worried that the independent providers are now just going to get more consolidated into hospital systems? When you think about a healthcare hero today, you think about the nurse and the ICU doc, on those front lines, and you're not thinking about primary care. Yet we're clear that these are the people who need to be out there in all the communities. So, but on the other hand, there's been a real movement towards consolidation and towards hospital purchase of all these practices. Many of them, I think, have actually closed because now those docs have been sort of, brought into the hospital setting. And so I just wonder, are you concerned about the fate of the sort of community providers that really are in these local, rural, low-income communities of color, who speak the same language and look the same as the people who live in those communities? Are you worried about that?
Yeah, we should all be worried about that. Half of primary care in this country is still delivered by those community practices. They're the ones who have the least margins, the least ability to weather this. And as there was a New York Times article about this, and the last paragraph was, the vultures are circling. And it's not just hospitals, it's also, there's, Optum's buying up a bunch of practices, and private equity firms are now looking at that. But look, the problem with those is that over the long run, that all that does is it increases costs, and it doesn't improve quality, and it reduces competition and choice for people. The evidence on that is just so crystal clear. And again, like, maybe not 3 months from now, 3 years from now, we're going to be looking back and saying, like, gee, why is it that healthcare costs are going up again, right? And like, we've lost competition. In some cases, we've lost access in those communities. Louise, you mentioned, we have docs who are the only primary care happening in that town. They're bought by a private equity firm, and then then it's not as profitable. Like, they close those offices down. That's what they do. So, this should be something that people are particularly if you're thinking a market-based approach to healthcare, should be very, very worried about. And I don't see the level of appreciation for the importance of this.
So let me ask another quick question, which is that, one of the things that happens is that people use the emergency room for non-emergent issues. We all know this. during the H1N1 epidemic in New York City, you know, the prevailing thought was maybe it was because people didn't have primary care access. And so we went and we actually talked to people in the emergency room, and they said, this is where we thought we were supposed to go. So my question to you is, and maybe Dave, you can take this one, is in your emergency rooms, you're seeing people come for things that are primary care issues that you would like to refer back to primary care, or really are people just coming because of COVID? You know, how are the EDs, you know, sort of helping figure this primary care emergency issue out at this moment?
Yeah, well, unfortunately, you know, I think the phenomenon that we talked about earlier predominates right now, which is that people who should be seeking care are not seeking care in any setting, you know, emergency department, primary care, or otherwise. And I think a lot of that is related to, you know, to the fear that we've alluded to. As I think we continue to move forward in the coming weeks and months, I think we're going to start seeing more of a phenomenon of that. But I really, you know, my belief, having you know, worked on this over the last few years, is that patients are very smart. You know, they go to the place where they can get care, and so the onus is on us to create, you know, better systems for what might seem like a low acuity issue, but maybe only after the fact. You know, chest pain can be a low acuity issue, but when you're having chest pain or shortness of breath, you know, you're consumed by the anxiety of that, and so you just want help. And so I think, you know, there's a lot that we have to do to guide those things. And I just want to pull one other piece from your previous question, Louise, which is that we have to pay attention to this as part of the conversation around health equity, you know, with COVID-19. And, you know, the market phenomena that Farzad alluded to, as always, you know, the people who are more likely to bear the brunt of it are the people who are least likely, you know, to have the ability to bear the brunt of it. And so, you know, in addition to the independent community providers, it's our federally qualified health centers and other community health centers. Shoring those up is the best way to mitigate the phenomenon that you're talking about.
So I'm just going to ask the last question, a lightning round. You know, give me your answer in 30 seconds. What's the most innovative solution to a COVID-related problem that you've seen addressed in primary care over the last couple of weeks?
I mean, I've loved all the approaches to parking lot testing. I think that was like, that came out so quickly, and it's not something that if I had been sitting in a, you know, pre-COVID planning meeting, I would have appreciated how quickly our practices adapted to the idea of, they put a, you know, and we help now make this a best practice, putting up call us first, and then messages to their patients, and then signs that if you have any of these symptoms, stay in your car. Text us at this number, and then we have one person who's fully geared up who will go to your car in the parking lot, talk to you, take a specimen if needed, and keep you separate. I just thought that the speed with which these practices innovated that approach within like literally like hours of this was so impressive to see.
Yeah, I hear that one community health center is doing parking lot vaccinations for children so they don't miss their doses. I thought that was pretty creative. Dave, what about you?
Yeah, those are great examples. I'll add, you know, in the spirit that all care is now COVID care, I'll share the example from some of our behavioral health colleagues here in New York City who stood up within the matter of days a virtual buprenorphine clinic for patients with opioid use disorder. Very low barrier to bup prescribing at a time that I'm sure you know, getting patients on medication-assisted treatment saved lives. So we were able to do that in a you know, a more accessible way than I think people would have thought about before COVID.
Right. Another great example about how the regulatory framework can change quickly if we make it happen. So I want to end by thanking, as always, an incredible pleasure, Dave Chokshi and and Farzad Mostashari, thank you for your insights. Don't forget to join all of us at our next 2 webinars if we have that extra slide put up there, and we intend to continue this conversation. Next time we'll be talking with Louise Mccarthy, who's the CEO of the Community Health Center Association of Los Angeles County, and Jen DeVoe, who is a professor and family practice doctor at the Oregon Health Sciences University. Thank you all for joining us today. I think food for thought and for immediate advocacy work. So we're thankful that you're both out there. Take care. Be safe.
Thank you.